Hi everyone, we're here to tell you about the Brunnstrom approach. I'm Lorraine McGann, Maureen Myers, and Joseph Tan. The Brunnstrom approach was created by Signe Brunnstrom. She was born in Stockholm, Sweden. At 17 years of age, she entered the Royal Institute for Gymnastics. The reason this is important is because of the fencing master that she worked with there, Henrik Ling. His techniques became the foundation for many of the treatment approaches that Miss Brunnstrom used in her future work. At age 20, she went to Switzerland and worked with a physical therapist. 1 year later, she opened her own institute, and it was there that she gained a reputation as a therapist working with children with scoliosis and poliomyelitis. She was also considered to be one of the greatest pioneers in physical therapy. And when she finished her work with children, she moved to patients who had hemiplegia, usually following a stroke. And that's what this approach is used for. The Brunnstrom approach is based on a neurophysiological treatment based on the use of reflexes to elicit movement. Stereotyped whole limb movement patterns are facilitated. Subcortical motion synergy can be elicited on reflex basis, and the PT or OT approach is based on synergy patterns of the limb and trunk. The basic premises for this approach is that when the CNS is injured, movements become primitive, reflective, and automatic. Change in tone, spasticity, and the presence of reflexes are considered to be part of the normal process of recovery and should be used to elicit movement when none exist. This is really important because the muscles are neurophysiologically linked. They can't act alone or perform all of their functions. If one muscle in the synergy is activated, each muscle in that synergy responds either partially or completely. The patient cannot perform isolated movements when bound by these synergies. Next, we're going to look at some of the reflexes that we studied a lot in peds, actually. So you remember the STNR and the ATNR. Flexion of neck results in the flexion of arms and extension of legs, or extension of neck results in extension of the arms and flexion of the legs. The ATNR, the head rotation to the left, causes extension of left arm and leg and flexion of right arm and leg, and the head rotation to the right causes extension of right arm and leg and flexion of the left arm and leg. Another reflex that we notice is the tonic labyrinth reflex, and you'll see this is it's initiated by change in the position of the upper trunk. And you can see when the baby's laying on the tummy, arms and legs are pulled in, and when the baby's on her back, all limbs are extended. There's also a tonic thumb reflex, which is if your affected upper extremity is elevated above horizontal with the forearm in supination, thumb extension is facilitated. There are associated reactions that go with these reflexes, and they are automatic responses of the involved limb from action that occurs in another part of the body by voluntary or reflex stimulation. It's commonly elicited when some degree of spasticity is present, which is normally in the third stage, and it's infrequently seen in limbs with minimal muscle tone. Most associated reactions elicit the same direction of movement in the upper extremity and the opposite direction in lower extremity. The Souques Phenomenon is demonstrated by elevating the affected arm above the horizontal level, which evokes extension and abduction response of the fingers. The Raimiste phenomenon shows that when resistance is applied to abduction or adduction of the non-affected lower extremity, it evokes a similar reaction in the affected limb. And the homolateral limb synkineses, a dependency exists between the synergies of the involved upper and lower extremities. Flexion of the involved upper extremity will elicit flexion of the involved lower extremity.
As part of the Brunnstrom approach, there is a sensory evaluation that takes place as well. Part of that is the joint sense, and this is conducted by the patient being seated and blindfolded. The affected upper extremity is supported by the examiner and moved to different positions. The therapist asks patients to perform identical position with the unaffected upper extremity. We have a video demonstration of this that we would encourage you to take a look at, and it demonstrates the joint sense technique that is used. Touch sensation is also another of the sensory evaluation. This again provides the therapist with information that's related to the client's sensory perceptions. The palmar aspect of the fingertips are touched with the rubber end of a pencil. The patient is asked to determine without looking which fingertip has been touched on the affected upper extremity. And also the sole sensation is another testing for sensory, and this is done on the lower extremity, and this again without looking. The patient is asked to determine if an object is touching and pressing against the sole of the foot or not, and again if it is, where that pressure is being applied to. The 5-speed test is utilized to assess the spasticity that is present during any recovery stage, as long as the patient has sufficient range of motion in the affected limb. The procedure for this test is as follows. The patient is seated on a chair without armrests and leaning back against the chair and keeping their head erect. There are 2 movements that are actually studied through the 5-speed test. The hand is moved from the lap to the chin, requiring complete range of elbow flexion, and then also the hand is moved from the lap to the opposite knee, requiring full range of elbow extension. The therapist will record the number of full strokes that are completed in 5 seconds, first on the unaffected and then on the affected side, to determine if there is a variation between the two. Brunnstrom is also well known for her 6 stages of recovery. The first stage is the flaccid stage, where there is no muscle movement whatsoever in the affected limb. And the second stage is the basic limb synergy develops and spasticity does appear. Number 3, the third stage is basic limb synergy develops voluntarily. The fourth stage is demonstrated by spasticity beginning to decrease, and basic limb synergies become available in the affected upper extremity or lower extremity. The fifth stage shows a relative independence of the basic limb synergies. And the sixth stage is shown as isolated joint movements on the affected and the unaffected limbs. And at that point, the therapist will then move into more complex therapy interventions. So overview of the treatment stages. The treatment must progress developmentally, which goes from reflex to voluntary movement to then functional movements. In stages 1 and 2, when there is no motion that exists, movement is facilitated using reflexes, associated reactions, proprioceptive and exteroceptive stimuli, as well as resistance. The beginning of stage 3 and then again moving towards stage 4 is demonstrated when voluntary efforts appear. The patient is to hold isometric contractions. The patient is asked for eccentric or controlled lengthening contraction, a concentric and shortening contraction, and then reversal of the movement between the agonist and the antagonist. The video represents the rowing technique utilized to produce contractions that aid in recovery of limb movement, and note the repetition of the movements that are done in the video. Continuing with stages 3 through 6, facilitation by the therapist is reduced or dropped quickly when the patient shows voluntary control. That is, the primitive reflexes and associated reactions diminish. Correct movement is repeated and practiced through the use of ADLs. All pathological and physiological methods of facilitation are indicated during the first three motor stages, and the physiological methods of facilitation are indicated during the recovery of stages in 4 through 6. The therapist will continue to reinforce the movement synergies and advance to the use of them through functional tasks, which may begin with eating, grooming, and then advancing to dressing and other IADL activities. The video demonstrates using repetitive movements of the affected upper extremity to perform an IADL task of washing the counter. And also stages of hand reactions, which is demonstrated through the Brunnstrom approach. It steps to restoration of hand function, Their attendant reflexes return and they become hyperactive. Spasticity develops and has resistance to passive motion. Voluntary finger flexion occurs, and if facilitated by proprioceptive stimuli, proprioceptive traction responses can be elicited by the therapist, and that includes proximal traction response, as well as stretch of the flexors of one of the joints of the upper extremity. And this facilitates a contraction of the flexor muscle of other joints of the same limb. Also, control of hand without proprioceptive stimuli begins. Number 6 is grasp is reinforced by tactile stimulus on the palm of the hand and spasticity declines. And then again, true grasp reflex can be elicited and spasticity further declines. Other hand reactions includes the instinctive grasp reaction, which a stationary contact with the palm of the hand will result in closure of the hand, an instinctive avoiding reaction that has with the arm elevated in an upward direction and the fingers and the thumb are hyperextended. Stroking the palm in a distal direction exaggerates the posture.
Assessment of basic limb synergies. Flexor synergies are utilized to incorporate movements needed for functional activities. The flexor synergy of the upper extremity include scapular retraction and depression, shoulder flexion, abduction, external and rotation, elbow flexion to the acute angle, forearm supination, wrist and fingers flexed. The strongest component is elbow flexion, and the weakest component is shoulder abduction and external rotation. Extensor synergy of upper extremity. Extensor synergies are also reinforced with the client to build in these movements with advancement towards functional use. This involves scapular protraction, shoulder extension, abduction, and internal rotation, elbow extension, forearm pronation, the wrists and fingers flexed. And again, the strongest component is abduction and pronation, with the weakest component, elbow extension. Rationale for use in OT evaluation. Research studies have found these techniques to be effective for clients recovering from stroke symptoms. An emphasis involves focusing on achieving voluntary control of the hand and finger movements. It also supports OT mindset for increasing fine motor control and ultimately independence in ADLs, BADLs, and other forms of occupation. Also provides guidance for the OT process of assessment, goal setting, treatment planning, and interventions. Research supporting and refuting the Brunnstrom approach. Pandian conducted a study that found significant results in motor recovery in favor of the Brunnstrom. And due to the Brunnstrom hand movement approach, direct acts on the wrist and finger movements, specifically mass finger flexion, extension and grasp, and an overall focus on motor recovery. The study limitations of this include small sample size, few number of therapy sessions, and unlimited outcome measures. Moving on to Smith's research supported the Brunnstrom approach as a tool for patients with hemiplegia and a supportive tool to emphasize motor control and motor learning. And lastly, we talk about Wolfdag. His study linked the Brunnstrom approach to Bovath's physiotherapeutic method. This supports Brunnstrom's foundational theory of the importance of facilitating the reduction of an enhanced muscle tone before voluntary motor activities are facilitated. Brunnstrom OT and OT scope of practice. Remediation and restoration. Movement restoration of an affected limb to regain function for everyday tasks and performance. Also to maintain, to keep the abilities they have regained through contextual adaptations and environmental changes, and also modification to revise the current context or activity demands to meet the needs of the client. Restoration for daily activities that involves dressing, bathing, and eating. Maintain these abilities that are regained, and then also to modify activities to improve occupational performance. For example, eating, we would adapt using a Dyson, plates with sides, adaptive silverware. Supports occupational therapy practice framework. Essentially, the Brunnstrom approach aims to create, establish, and restore. It also aids and assists in recovery from hemiplegia with negative impacts, which negatively impacts occupational performance. Another aim of the Brunnstrom is to promote engagement in occupational life activities, leisure, work, play, ADLs, BADLs, performance skills, motor skills, and moving and interacting within the environment. Lastly, we'll have an activity for everyone to try. They can do this at home. The instructions are on here. Secure a partner and have one person act as a patient and the other as a therapist. You'll need a pencil with an eraser attached. The patient will have their eyes closed or blindfolded to obscure vision. The patient is also seated with feet on the floor and their back against the chair. The patient will extend arms to reach out at shoulder level, and the therapist can support the affected limb as needed. The therapist will then touch random fingertips of the affected limb with the eraser end, and then the patient will try to tell you which areas of their fingers or feet are touched. And this is to determine the extent of sensory impairment following a stroke or other neurological impairment. Lastly, here are our references. Thank you for listening to our presentation on the Brunnstrom. Have a good day.